Good
Morning.
Just gonna take a minute. Wow, everyone got connected pretty quick. That's great. Thank you guys for being here this morning. Okay, I'm just gonna let a few more people in and we'll get started. Well, good morning, everyone. I'm Brianna Yoakum. I'm the Director of Accreditation for Walker, the Washington Alliance for Quality Recovery Residences, and we're so excited. We have Sarah McCain here this morning, who is going to just educate us on a very important topic as it relates to childhood trauma and ACEs and how we can better utilize this information and put it to use in our recovery residences or in our places of work. So we're so excited to have her. What's going to happen is this meeting is going to be recorded. You guys can put questions in the chat, and me and Sarah Carr, who's going to be helping out in the background, will help bring up the questions to Sarah from the chat. We will also have this again recorded and the slides as well that we could share and send via email. So with that, I will pass it on to Sarah.
Hi, everyone. Good morning. So my name is Sarah McCann. Have been in the substance use disorder field for about 10 years, with the last 3 years being in clinical supervision. I'm currently set to end and graduate with my master's program in December, and I am working in a resident house for my internship program. And it is community partners with the therapeutic courts. So it is an interesting dynamic. And it's just awesome to be able to be here with you guys this morning so we can see how we can better fit the clientele that are in the house. So I'm going to go ahead and share my screen. Everyone see that all right?
We do see it. If you start it, it would make it full page for us to see.
Perfect.
Looks great.
All right. So, like Brianna said, we're going to talk about adverse childhood experiences, ACEs, and childhood trauma and the impact on substance use recovery homes, how we can better treat everyone who's living in the homes, have them line up for great success. I know all you guys are in the field or working where you are because you want great successful outcomes for these individuals and participants. So the objectives that we're going to go over today is we're going to understand the concept of ACEs, understand the impact of childhood trauma on brain development and behavior, identify, I can't fully see my screen, but that's all right. Let me see how I can minimize you guys. I got it, figured it out. Identify the correlation between ACEs and substance use, and learn strategies to address trauma in substance use recovery settings. Does anyone have any questions or comments on the objectives that we have going on? All right, we'll jump right into it. So what are ACEs? So I don't know how much you guys really know about ACEs, but it's an adverse childhood experience. So this could be any traumatic event that occur in childhood. So this usually is abuse, neglect, any childhood household dysfunction, and they're broken up in typical categories. So physical abuse, emotional abuse, sexual abuse, physical neglect, emotional neglect, household challenges. So any children that are witness to domestic violence, they would be victims themselves of domestic violence, substance use, mental illness, parental separation or divorce, incarceration in the household member. And we'll get into a little bit further in the PowerPoint of how resiliency and different risk factors actually impact the level of how the child responds to an ACEs and how their risk for substance use or mental health issues or other behavioral issues may come along. So the impact of ACEs can have, it can have a significant impact on individuals' physical, mental, and social well-being. This increases the risk of various health problems and social issues later in life. A lot of people who end up in the field that we are in, we are healers. And a lot of times we become this route because we didn't have what we wanted as children. And so it's just really interesting looking at this, the ACEs study and how it impacts brain development and how we ourselves are healing and then how we can give back to others. So many times ourselves in the field are ACEs adults. So the ACEs study, it's a groundbreaking research project. It's been around forever. I don't have the date, but forever. Between childhood trauma and long-term health outcomes. So it's not just behavioral health issues. It actually explores like heart disease, just all these physical aspects that impact long human development. So the study that individuals experience multiple adverse experiences during their childhood, like the abuse that we talked about earlier, really impacts so heart disease, cancer, mental health issues. It has long-term impact. So what we're looking at is dealing with the adults, right? Because we're working with the adults that have majority of the time did not turn to a healthy coping skill or resiliency factors for any childhood experiences that they had. So what we're looking at is how to handle these adults, how to really make it to where they have a successful outcome. Because I'm sure many of the adults you deal with may have dysregulatory issues. They may have resistance to change. They may have all sorts, which unhealthy conflict resolution skills. So that can trigger some parts in us, right? So it's really giving us some skills to navigate that and understanding where they come from, where we come from, and how we can get a successful solution. So now we're going to take a deeper look of how ACEs really impacts brain development. And to me, this is so interesting. I don't know if you guys have really explored ACEs, but the abuse and household dysfunction impacts the structure of the brain, leading to changes in the brain function, cognition, emotion, and behavior. So it really impacts the brain arousals and difficulty regulating emotions. It decreases brain volume in certain regions, such as the hippocampus and the prefrontal cortex, which is decision making and everything that we're memory, and it's a huge navigator when we're looking at not only children, like where we were to look at a classroom, or the adults of the children. Adults can impair the development of executive functioning skills such as problem solving, decision making, and impulse control. I mean, I don't know how many of you guys are in a recovery home right now where your individuals and participants are really working on learning and reconditioning their brain for impulsivity. It's a huge one, and this was rewired in their brain since they were a child. Not, I mean, for the most part, most of the individuals you were dealing with had ACEs, right? It's not every single person, but for the majority, we're gonna, assume from the study and the statistics that a lot of people who end up in these recovery homes are attempting to heal. So their impulsivity control, their consequential thinking, all these things they're trying to recondition their brain. And it's hard. And this is where we come in as skilled individuals and case managers to help them process and just move on a little bit into the direction of their individualized goals. So, and then, individuals with ACEs are a higher risk of developing mental health disorders such as depression, anxiety, and post-traumatic stress disorder. That is an unfortunate of what we're dealing with in society. And it's just really awesome that you guys are all here to see how we can help. So specifically to substance use disorders, because the participants in your household all have substance use disorders, how it relates to ACEs, and you could probably just use this for your critical thinking skills of course, that's the line, right? And especially in your lifestyle that you've seen. But there's actually links and studies and evidence-based practices that show that individuals with multiple ACEs, so that's not just one, right? They have multiple categories of an adverse childhood um, experience are up to 4 times more likely to develop a substance use disorder. So many times these child are not just dealing with one trauma if they're in a dysregulated household. They've experienced multiple things that have dysregulated their brain and made it unable to cope with natural stressors, right? So then we move on to the self-medicating behaviors, right? Because we were not shown or told or modeled any healthy coping skills if we're in a dysregulated household, or if given the example of maybe if someone experienced one of these abuses but we're in a regular stereotypical healthy household, with which of course still has some negative experiences, they are less likely, because they're not up to the 4 times more likely, they're less likely to develop a substance use disorder. So let's say if a parent or a guardian was able to see that the child needed some help, they showed them help, they got them into mental health counseling, maybe extracurricular activities, they would be less likely to develop a substance use disorder. Is it impossible? Of course not. We're just looking at like the majority of where this ACEs study ends up with substance use disorders. So, and we all know, if we do not have healthy coping skills, we're going to find coping skills. We're going to find what works. And this is usually self-medicating behaviors. And so it's a coping mechanism. It's an unhealthy coping mechanism, but we turn to manage the emotional and psychological effects of traumatic experiences are easy with alcohol and other drugs. Are there meeting questions? I'm sorry, I got a notification that there were maybe some meeting questions, or that was just an AI tool. Who knows?
I think it's just AI, but I think
Yeah, because you guys
they
saw
have
what was popped
questions
up,
that
huh?
will pop up. So I'll let you know.
Perfect, thank you. I don't want to run it through it too quick, but I want to, just give a brief background on ACEs. So now we're going to go into some different modality tools. Does anyone have any questions or anything you want to share about the ACEs study? All right, let's move on. So when we're integrating ACEs assessment, so I'm sure you guys all have different screening tools when individuals enter into a residence, but there's actually ACEs questionnaires, and they're listed right here that you could grab if you wanted to put it into your paperwork, your assessment or intake paperwork. So you could, give you a little insight into where the clients are coming from, if you feel comfortable adding that in. There's also there's specific trainings that you guys may want to attend if you guys are going to utilize the ACEs questionnaires to know how to score and interpret them. It really does come with some compassion and empathy when you're dealing with the ACEs questionnaire, and we're going to want to make sure that you have the time in the intake process to incorporate that if that's something that you're looking on doing. We're going to talk about the trauma-informed approach, but this is just a safe, empathetic, non-judgmental environment for clients. So that's just trauma informed, right? So we're not doing any trauma therapy on the clients. We're just trauma informed. And that is within your scope of working in the house manager or any other positions that you have with when you're working in residencies. So resilience is a huge I don't know, buzzword, I guess, in our field, right? But it really is something that is impactful for these clients. So when we're looking at their score factors and we're looking at their childhood trauma, we also kind of want to balance that into what their resiliency factors and strengths are. So when we understand resilience, so resiliency is the ability to bounce back from adversity, adapt to challenging situations, and maintain a sense of purpose and well-being. It takes a while to get there, and even small steps, low-hanging fruit will help you out with that. And there's coping strategies. So this is a skill that can be reformed, taught, and expanded on, right? It's not just I wasn't born with resilience. This is a skill we can expand on, and this is something that you should all be instilling in any participants that you work with. So it's teaching techniques like mindfulness, problem solving, and emotion regulation. This will develop the coping mechanism, and these things actually reshape the trauma that impacted their brain from the beginning. So this is going to reshape their brain neurotransmitters. And this is what is going to ultimately lead them to long-term recovery, because it is achievable with these things. So their social support network emphasized the importance of building a strong support network, connecting with family, friends, and community resources. I'm sure you guys all know how important the social support network is, but it rebuilds their resilience factors. Fostering resilience, encourage clients to engage in self-care, find meaning and purpose, and cultivate a positive mindset to build long-term resilience. Resiliency is so awesome to see in a client who has been struggling. It really just is so heartwarming and gives us purpose to why we're in this field and why we're, fighting such an almost sometimes it seems like an unachievable goal of substance use, but it's a big one. And especially if someone's already in the recovery residence, they're showing the motivation and change talk to want to achieve success. So there are therapeutic approaches. Let's say you're working with a client and you see that they rank pretty high on the ACEs scale. They could benefit from some therapeutic approaches that they may not be involved in, or you could give them maybe you can have a list of counselors in your area that have trauma informed approaches, because these will typically be outside of the scope of practice. Like, I'm a substance use disorder professional. This is outside my scope of practice. It's going to be outside of anyone who does not have a specific licensing to provide mental health. And damage can actually be done if someone who is outside of our scope of practice tried to do one of these trauma approaches. So we're going to talk about, these are just 3 of the trauma informed approaches, but if you want to go on Google or Psychology Today, or if you already have a community network of therapists within your community, you could ask them, hey, do you do EMDR? And then if you have a participant in your household, you would be able to refer them there. So we have the dialectical behavioral therapy specifically for trauma. So this was originally developed for borderline personality. If you've ever heard of DBT, it has been adapted to treat trauma-related conditions. DBT focuses on balancing acceptance and change, which is particularly helpful for individuals with ACEs, and also for intense emotions linked to trauma. So then there's also the eye movement desensitization and reprocessing, EMDR. EMDR utilizes rapid eye movements or other bilateral stimulation to help the brain reprocess traumatic memories, allowing individuals to gain a new perspective and reduce emotional distress. Trauma-focused cognitive behavioral therapy. So CBT is something that most individuals in substance use treatment are doing naturally, right? They're retraining their process, they're catching every single thought and reframing it, which is basically a full-time job. This focus of CBT is more on focusing on traumatic experiences. So developing coping skills and promoting emotional behavioral regulation in individuals, especially children and adolescents. So, and a lot of times you're working with individuals as well who have children, right? You're in their home, you see their whole family aspect, what they eat, what they drink, their sleep cycle, all those things. And so if you think that maybe also their children could benefit from any of these therapeutic approaches, this would be a good tool to, know about, understand the therapeutic approaches. There's many other trauma ones. These are just the main ones that I thought would be useful today. So trauma-informed care. So this is where we're going to go over how you in the house could utilize trauma-informed care, knowing that a large majority of your participants in the home and individuals that you come into contact with have been exposed to some sort of trauma in their childhood, even more in their substance use. It's a lot. It's a big end game for them. So trauma-informed care is really just the basis of understanding trauma. Trauma refers to experiences that are emotionally and psychologically overwhelming, and that can have a lasting impact on a person's mental and physical well-being. Key principles of trauma-informed care. Trauma-informed care focuses on recognizing the impact of trauma, emphasizing safety, promoting empowerment, and ensuring a collaborative approach to treatment. So when you're thinking about when you feel safe with whatever providers you go with, this can be doctors, it could be mental health providers. You can use your insight on reflecting on who you feel safe with, right? And it's usually those people who are not telling you what to do. They're saying they're inviting you to use your autonomy and figure out goals together. This is what we want to do when we're talking with individuals who are um, looking to get into recovery and have a history of childhood trauma. So we want to create a safe environment. Trauma-informed care prioritizes physical and emotional safety, minimizing triggers and creating a welcoming, non-threatening atmosphere for individuals seeking support. So we really want to emphasize empowerment, right? So a lot of times the clients that we're dealing with are going to, or participants, whatever you guys call them in the household, they're being told by their family members, by their, it could be children, by their moms, dads, employers, treatment providers, oftentimes courts. They're being told what to do in almost every aspect of their life, which is good for, good for this, for some part, but we also want to teach them and guide them into making their own healthy decisions when the courts and treatment providers kind of phase out. So this is when we really want to emphasize empowerment. So trauma-informed care encourages individuals to take an active role in their own recovery, recognizing their strengths and promoting their autonomy. And this is huge when we're talking about freedom, because they're breaking away the chains of addiction and really becoming their own person. And we want to trust in them, and they want to trust in themselves that they are able to make their own decisions. Trust is such a huge thing that is taken away from anyone who's experienced any trauma. And regaining that tool is huge. And being a part of that autonomy learning skill is also huge. And this just really goes into the collaborative approach. Trauma-informed care is a collaborative approach process with individuals actively involved in their treatment plan and decision making, and providers working to build trusting relationships. And this also goes along if you're working with a participant. I'm sure you guys have advocated for friends, family members, participants in the household. You're welcome to also advocate for them if you feel like their autonomy is being not going into a trusting relationship wise in certain aspects, where we're building boundaries. So we're gonna dig a little deeper here in 5 trauma-informed approaches for creating safe, supportive environments. Before we do this, we're gonna go into a little role play. Well, would anyone like to role play a participant of someone coming into a residency household, maybe been there for about a week, pretty resistant, but open to change and has a little bit of change talk. And has some who rated pretty high on an ACEs trauma informed an ACEs rating scale. We could have two people, one who's trauma and one who's like peer support or case manager in the house.
I'll be trauma.
Thank you, Christina. Who's gonna use some trauma informed approaches for Christina? You could either utilize poor trauma informed approaches for creating safety or positive. We could see whichever one. Poor Christina.
Nobody wants to help me.
No, re-traumatizing. I'm gonna give it a minute. I'm gonna have to do it.
What's the question?
Hey, Devin, I was hoping someone could role play with Christina. So she's going to be a participant in a household for in a recovery household who has rated high on the ACEs scale. So she's had a lot of childhood trauma, and I would like someone to either role play with her as whatever, a peer support case manager, whatever you are in the role in the house, as either responding to her in a poor trauma informed way or a positive. You could choose.
Okay,
You want to do it?
sure. Why
Right
not?
on. All right, Christina, you're meeting with Devin, and you're telling him where you come from.
Devin, the house I'm staying in is so mean. I'm meeting my boyfriends, but then they say that they can't be knocking on the door at 11 and 12 o'clock at night. And I'm just scared because they kicked me out of the place. And they lied and said that I threatened to hurt them and stab them with a knife. I don't remember doing that. And then they said I threatened to light the place on fire. I only did that because they don't respect me, and they said that I don't respect them. But I even saw my last boyfriend, and he beat me up, and I have nowhere to go. And I'm working this gosh provider, and she keeps saying she needs the addresses, the places I live, but I'm so overwhelmed I can't even do that. And now the home's kicking me out. And I just know I'm gonna die on the street. I'm gonna die on the street because nobody cares about me. I don't want to die.
I don't want you to die. Wow, that's a lot. So I would say a negative way would be to just turn everything back on her and bring up the negative things. I would say the positive way would be to try to stop the bleeding and find an emergency care facility for women who could possibly, intervene in this situation. Right?
Yeah.
I'm not going to another adult family home. I hate this adult family home. They lie about me. They're mean. I'm not going. And
Well,
why should why should I have to do the calls? People should be calling out to me. I'm the one who has needs.
Yes.
I understand
Christina,
that.
you did such a good job of role playing the client with the most needs in the household, right? So I think when Christina started talking, did we all think this is the clientele that I would right? So this
Yeah.
is a clientele that we really need trauma-informed approaches with, right?
Yeah, for
Because
sure.
This is this is my current client.
is
Oh
it
my God.
the easier clients and the ones we build rapport with so easy, they are the trauma-informed approaches. We can create safe and supportive environments because they kind of meet us a little halfway, right?
Yeah, for sure.
Christina is the clients we've all worked with where we're like, this, it's too much. It's learned helplessness, right? But when we look at the cycle of ACEs and how it reformats our brain, Christina's working with what she has, right? Or the
Yeah.
client, right? Not Christina in general. But so this is the client that we really need to do the 5 informed approaches. So I want to go over the first approach of how we would deal with the client that Christina showed us, because that's where we really need to navigate the skills, right?
Right.
Thanks you guys for stepping in. Man, I don't even know what I would do in Devin's shoes in that one. I would just like you did good, Devin. We might want to get her somewhere else. Right? Because at a really critical skill in balancing the household is not only what is helpful for the current person we're dealing with, but also the whole house, right? It sounds like the client that is being case studied right now is impacting others' care, right? We're really, it comes into just a whole field of who we're going to do. Okay, so the first one is choosing safe residence for clients. I don't know. Oh, I got this. Oh, wrong one. Back. Perfect. Creating safe spaces for residents. So physical safety, right? So we're ensuring the environment is clean, well lit, and free from triggering objects or situations like excessive noise or confrontational posters. I don't know if you guys have ever seen clients have remarks on like weird posters sometimes. I don't know. Emotional safety, avoid shaming, blaming, or labeling residents instead use validating language and show that you are trustworthy and non-judgmental. Basically the rapport stages. Consistency, stick to predictable schedules and routines to help residents feel a sense of stability, as trauma can disrupt trust and create fear of unpredictability. This is huge. If you start like a morning meeting at 8, you make sure that morning meeting is at 8. If you tell someone that you're going to be somewhere at a certain time, you be there at a certain time, or you keep them updated. These tiny little things really are able to just reform the brain when we're creating safe spaces. Non-intrusive, allow residents to have control over their personal space and avoid forcing participation in discussions or activities. Giving residents the autonomy to decide when to engage can foster a sense of safety. So when I have a morning meeting that I utilize in my resident house right now, it's basically just goals on housing employment. Obviously recovery comes up in almost everyone as certain, cravings are coming up, football started, yada, yada. And if I'm ever doing a group activity, let's say I have these cards that I spread out and I'll say like, pick which one symbolizes drug court or whatever, for example. I'll never say Pete, share. I'll say, who wants to share? Who wants to share next? Everyone usually ends up sharing because they feel like it's a safe environment. I'm not forcing anyone to do. This is just a good project model that I do for usually when I'm in a group setting. I definitely encourage you guys to utilize it as well. We don't force anyone to share unless, of course, you guys can use your insight if it's a necessary, if it's a necessary thing that we're going to share. So non-intrusive, allow residents to have control over their personal space and avoid forcing I already read that one. Yeah. So but the residents having control over their personal space, as long as it doesn't impact another resident in the house, right? We're going to be clean. We're going to learn those skills as well. There's so many skills that these people are navigating in early recovery, right? So number 2, so these are all trauma-informed approaches. So number 2, active listening and empathy. So for Christina's case client, what we really want to look at is I don't want to get too ahead of myself, but for the first 2. So does she have a safe, clean environment? Is her brain short circuiting because possibly her environment is a mess? Do we need to create a safety issue there? Are we allowing her to choose what she's going to be a participant in? Because we're not going to want to force her into another things. Let's say we could meet her halfway of like, what's one small thing you want to work on for this? Or it could even be a lower language barrier than that, because it sounds like that there may even be some cognitive or mental health or substance use currently going with Christina's client. But we want to make sure, let's look at first the trauma is there, right? She probably scores pretty high on ACEs. We want to see what we can do in just low hanging fruit type things. And then we want to go to active listening and empathy. And this is where Devin was really like, well, we don't want to put all the blame on her, right? How is she going to receive that? She's just going to argue. Basically, you will always lose if you end up in an argument with a client, and you lose because they're not going to hear what you have to say. It's just how it goes, right? So we want to practice active listening and empathy, which can be hard when we're dealing with a client like Christina shared, because it is just like they're drowning in like a little puddle, like just stand up, where they're creating the majority of their problems themselves. But telling them that is not going to go anywhere, right? We want to show them a safe space so that when they're open to actually hearing some changes being made, they trust you. So eye contact, super important, right? We're not going to be looking at our phone. We're not going to be looking over at someone else. We're going to be looking at them. So maintain appropriate eye contact to show engagement without being intimidating. Obviously, I do not think any of you guys are being intimidating with your eye contact. This is also nonverbal cues. So nodding, using open body language, and offering comforting gestures, leaning forward slightly, indicate that you're present and engaged. All these little things are huge. So reflective listening. It's also called mirroring. Repeat back or paraphrase what the resident is saying to show understanding and ensure you're capturing their emotions accurately. So example, it sounds like you're feeling really frustrated because things haven't been going the way you hoped. Is that right? Christina, have you noticed that reflective listening does create like a positive sense of safety with this client?
Yes, it does. And the biggest thing with her is saying, okay, I was over there 2.5 hours one day, 2.5 hours going between her and the apartment, trying to negotiate some kind of truce for the weekend. And the place had hit all their knives. And I just got a message while I was in this training that they had to call the police again last night because people were knocking on the windows and the other residents didn't feel safe. And she's been given a 30-day notice to vacate from the adult family home. She refuses to go to another adult family home. She's having men pick her up. I guess she came home the other day and had gotten some altercation and had bruises on. She, the biggest part of what's playing into the problems here, and I don't want to blame the adult family home, but I've talked to them and this is, we need to come in and clean your bathroom. And the client says, I'll clean it. And they continue to argue with her. I says, she needs a safe space. And when you're coming in here, she's feeling like she's not having that personal space. And they're like, well, no, we need to clean the bathroom. So part of what is escalating her is the adult family home staff. And does she lie about things with adult family home staff? Yes. But then when I go to adult family home staff, their stories are so different that I don't know what the truth is. And then I'm going to say something, I'm not making an excuse, the client lying, I'm not. But I don't know if the client is so emotionally amped up that she has a hard time remembering the exact facts of what happened. That doesn't mean she has a right to say she's going to burn the place down. But maybe she really cannot remember, then tries to fill that in after the fact.
Yeah. Yeah, and that's going to happen with most of the clients we're dealing with are not going to, they're going to go places or engage with some sort of community partnerships that do not have acting listening skills and empathy. They're not trying to create safe spaces, right? And it could be a sense of poor environment or a wrong environment for sure. And it's not the point of who is lying or who's right when we're dealing with these clients. And I'm sorry you're dealing with that, and I'm sure we all have a caseload with someone like that on our schedule, and that takes up the majority of the time. Like, if I didn't have anyone else, this would be just my sole caseload, right? Hopefully you can talk with your management team and your supervision team to really get the resources that she needs. And it sounds like you're doing everything that you can, right? You're not blaming, you're not shaming, you're having a non-judgmental stance.
Well, okay. I'm just going to be candid because we're in a group that's here to help me. So I told her, I says, yeah, we want to apply for an apartment with you, but I need the addresses of where you lived. And she's very young. So the case manager doesn't have that information of where she's lived. And she will not provide it to me. So, and I need that to apply for apartments. And she continues to not give it to me, saying, I will do it, I will do it, I'll do it. And it's been a month and she won't follow through on anything. And when I scheduled a meeting to meet her once, she goes, oh, I have this meeting I have to go to. And then I found out later it wasn't a meeting she had to go to. She was hooking up with a boyfriend.
Yeah, and that's the thing too, is we're not going to work harder. I mean, we all have our different philosophies and values and morals, right? But we're not going to work harder than someone else, right, on our caseload. And that's a huge thing of where we want to prevent the burnout on us. I'm not going to work harder than them. And you could tell them that too. And it's a good boundary, but it's still like, I'm a safe spot. I hear you, but I'm not going to work harder than you are on this, And I don't know everything that you have going on, or if you have certain time constraints where you're working on with this client. But a lot of how you can make sure to maintain yourself and everyone else on your caseload is the balancing.
There you go. There you go. And there's still boundaries. Excuse me for just speaking in, but we have to have those boundaries because it allows us to best do our work to support them. And they have to understand their boundaries and accountability, I feel like. Even though they're having situations or ACEs, we have to be accountable because there's a repercussion of that. And so even if it's put out there blatantly, maybe some tools, some ideas or ways to show them, if you do this, this is what would happen, so that they could look at that and remember that, going over their goals of what they want to do, reiterating that to bring them back to base when they go in those spiral places. Like you said, active listening, and then how can I help?
What
What are we
I've
gonna
talked,
do?
sorry, what I've talked to her about before is we are a client-driven program. So how that relates to her is I told her this program is voluntary. You don't want the program, let me know, but there are expectations if you want to be in this program. And I'm not going to pick the apartment for you because it's your apartment, and I can contact places, but I can't even apply to an apartment if she won't tell me where she's been living in the past. I don't know why she doesn't want to do that. It's like she's got so many walls up that nobody will help her. And the biggest issue is the continued abuse to everybody in the home.
And she's experiencing continued abuse currently. So yeah,
Yes,
it's
she
a
was from the men. From the
Mhm.
men she hooks up with, yes.
Mhm. Is it Tier? What was your name?
Yes, Tier.
Tier. Hi. Yeah, thank you for adding that. I do appreciate it because the boundaries help create the safe space. The safe space. For sure, 100%. It's the routine, it's knowing what's expected of them, and it also creates a safe space for us. So I'm happy that you added that.
Thank you. I didn't mean to butt in. I wanted to raise
No,
my hand
definitely.
but I appreciate you both, Christina and Sarah. And I just know that these issues, it's like hemorrhaging. And so you're inside, it's all internal, right? But then it
Hmm.
starts to bleed out and that blood gets on people.
Hmm.
And so doing things to stop some of the bleed out is what we're really here for. And I just appreciate you all. Thank you.
It's hard to watch. It's really painful to watch. Um, and it's so hard because we tell her these are your choices, and now she told the home she's pregnant. I don't know if that's true. Um,
Sarah, I had a question from Ronita. Ronita has her hand raised, so I wanted to make sure we got to her too.
Yeah, hi guys. So I have a situation kind of similar in this vein with a resident, and I I've been trying to be patient with her, but it's agitating or activating me. And we kind of bump heads a lot. And then we'll come around, apologize, because I'm a peer as well. And I'm letting her know, we can't keep having this clash. And I think it's more or less of a power struggle because it's an older person and stuff. I'm being respectful, but at the same time, I'm like, this is the program rules, and you're aware of that, and it's a volunteer program. And if we can only accommodate you so much. It like to play the elder card, so to speak. And I'm like, well, it's not an adult family home. It's a recovery residence, and that's one of the reasons why you're here. And this is our program rule set up for everybody, but we do try to accommodate as needed within our program rules. And I think because this is, older person, and you used to doing how you want to do when didn't have structure. Now
Hmm.
you're coming into a structure and an expectation and accountability, and like Kristen said, not producing things that I need to complete a complete intake. And so it's just got to the point where yesterday we had a real blow up coming out to our vocational program. That was in the morning. Later on, coming home, it was a full day. It was okay, but then I needed to do a random drug test. And so it was marijuana was found in her system, what she said is a medical, but I never got that on file. Okay, I need to see the medical. So this is out of order. And just with us bumping heads and couldn't pay rent this month, she maxed out the funds that was available, telling her, okay, you're gonna be responsible this month, but buying everything else, like from Tamu and everything. So I'm like, okay, I have to put my foot down now. So I told her she has to leave. And she was doing her own thing, trying to get rent and everything. She came across a resource, but I told her I don't think it's going to be a good fit because I'm being activated. Because we keep bumping heads around the same thing. And I really want to work with you, but I've been letting you go with stuff, and you're coming back at me saying, well, making excuses basically when you agreed to the program rules. And so I don't want to do this, but I feel like I have to put my foot down because you've been here 3 months now, and it's just been contentious. And some
Hmm.
days we are good and we can apologize. She's a woman of faith, so am I. But then some things like don't want to be corrected because again, I feel the undertone is because I'm older. I know more than you, and I can, but I'm like, but you're in this program, and this is how we're operating it, and it's a volunteer program. So and I've been giving grace. At the same time, I'm looking at my mental health and things like that, and how it's kind of going into other residents. You know, I'm seeing some things that's how it's being influenced by other residents. It's so I'm feeling some kind of way because I have to put my foot down. At the same time, I'm still kind of seeing if I can squeeze a little bit more grace out. But
Renita,
it's
what are these client? What are the strengths of this client?
very intelligent, has a educational background, have experience in running her own transitional house and everything. She's a person of faith. We are a faith-based organization as well. She has good qualities and stuff, but me and her is like she don't want me to enforce our program rules. It's like that's not how I want to do it and stuff. And you have to make exceptions for me because of my age. I'm like, well, not necessarily. So, but she has really good strengths, and that's why I want to see her succeed and be here, and she want to be there, but we keep
Mhm.
having this contentiousness. And
Do
I'm
you
like,
think giving her something to keep her engaged, like a project for the home, or
that's what
like she
we
can pick something of engagement so she feels more connected in the home and she wants to, did you do something like that already? Is that
Yes,
what you're
we
saying?
had talked about that over the weekend and about doing a Bible study. She wanted to
Oh
initiate
yeah.
that with some of the ladies, and I said, well, yeah, go ahead, let's do it. Let's go talking about a better eating, nutritious and stuff. But again, nobody have not been following our menu, but we were talking about getting back on the track with that. At the same time, it's the beginning of the month and she has to pay. So it's like
Yeah.
all these excuses, and she knew she should have been put her stuff together, budgeting and coming and talking to me. And she's
Mhm.
like, well, this is how I want to do it. I don't want to, I want to wait till we get home and then when it's time. Well, I'm tired now. She's making excuses and trying to manipulate stuff. And that's activating me because I'm trying to bear with you and give you grace because I know this is a big change for you to come into a safe space
Mhm.
to have and to have a structure. But you're
Mhm.
trying to tell me this is not how I can't do this, but you agree to these program rules.
So that's pretty typical client behavior, right? Why
Mhm.
do you think it activates or triggers you?
Because I'm a peer as well, and it's bringing a disruption to
Mhm.
the other residents that's because we have two new people
So what
and
are the consequences for her actions? Is
and
she going to
that
be
part. So
Mhm.
I think because she hasn't really seen anything, like we'll like I'll tell
Mhm.
her well, it's not acceptable, and then we get into a back and forth match. And
Don't
I'm
back and forth with her.
and I'm like, okay,
Yeah, keep the my sentence that I just said in your head. Don't back and forth. You're not gonna win. You're
exactly.
not gonna win. Yeah.
But at the same time, because we are women of faith, we'll
Uh-huh.
step and say we apologize to each other
Yeah.
and make amends. So that's good. At the same time, it's really
It's
activating
triggering
because
your
we
mental
keep
health.
going
You're
at
gonna burn out.
exactly. We
And
keep
you
going
can't
at it
provide
on
to
the
your
same
other clients on your
things.
caseload
And
if you have yeah.
that part. So it's like we keep coming to the same thing. And I feel like the underlying thing is a power struggle because you want to do what you want to do and you don't, and you want me to accommodate, but I have to do that for everybody else. Why you can't follow the rules of the house like everybody else? And blatantly in my face, and I try not to say anything on the phone through I'm like, and so this is now I'm at the point where I put my foot down yesterday and say, well, I don't think this will work with us, even if you pay the rent. It's just it's hard for me because it's
Mhm.
activating. And
Understandable. Yeah.
so and so we have agreed that she'll be, getting her stuff out by Monday and things
Oh,
like,
okay.
and I'm hoping, I don't know, I have faith, but I'm like, I cannot keep going back with that contentiousness because it's messing with my peace
Mhm.
and stuff. And again, she has done great things because She just completed her peer training and passed and everything like that.
Wonderful.
And this was another big contentiousness. She wanted to go to work and say, "Oh, you stopped me from working our program rules. You have to wait till the 5th month. You can go back, but you look what you're doing now. This line of work that you want to get into," because it was one of those little temp things, doing security work at events. And again, you're just coming in. You can't just go how you want to go because I don't know what you're doing in between work and here. So she was not. She did submit, but all about, well, you stopping me from I can't pay this and that because I don't have no money coming in, but you have enough to pay what you need, to come. So it's just been that kind of stuff, making excuses and trying to manipulate for how she wanted to go. And I've been seeing her yield, but it's like the contentiousness of it. It's
So I
like,
would encourage you to really try to implement some reflective listening. So if someone says, "You guys won't let me work," I would say, "Oh yeah, you feel like we can't let you work," or "Oh yeah, just repeat back what they said to you, not or even just okay. If you feel like it's disrupting your peace, just okay, because they'll stop getting at you, and you're still giving that trauma informed care, right? Because they're not ready to hear. If they're saying something like that, they're not ready to hear anything back. They're trying to be um defensive and try to bait, right? And that's typical client behavior. It's nothing personal on you. It's how their brain is rewired from protecting themselves from trauma for years, right? And if we have also experienced trauma and haven't fully healed, we're going to, our brain isn't fully healed. So it's really just a roundabout. But if we can also condition ourselves to just, it's really just reframe it to like never get into an argument with a client. Never, you never can say never, right? But never, I really will not engage. It's like a tug of rope. And once it's being pulled, I let it go. I
and
don't ever I don't ever pull it back. It's just okay. Or once I feel, and you can use your insight when they're ready to be receptive, right? Then you could be like, well, this is our program rules. Like, I know that's frustrating. I know it sounds frustrating. And, just kind of just, because it sounds like not going to go very far into recovery, even though she's still doing pretty active in engagement, right? If she's a peer support specialist, she may just transfer over these behaviors to
and
someone
that's
that she has like power over, and is still another, and hopefully one day she could learn these techniques as well. um or just nod, like the nonverbal cues when she's saying that. Just use the open body language, just nod, just don't even respond. If you feel like it's going to hurt your peace, just nod, and she's going to get better from saying, well, these are the program. She knows the program rules. She's a peer
yeah.
specialist and she's been in the field. You don't need to tell her. She
And
knows.
that's the point. She is just becoming the certified peer. At the same time, we have gotten to that place where I'll nod and then we get what we could talk and communicate. She apologize, I apologize. But then you do it, so it's activating me because I'm like, you're not a child, I'm not a child. And so I want to, like, why are we doing it's so it's like I cannot take it. So and I'm
It's
trying
typical
to,
client behavior.
yes. But
Yeah.
it's really interfering with my peace. And
Yes.
so, but I'm hoping that we can resolve it where she won't have to, because I believe it's a good environment for her. She got a lot of things that she can offer,
Yeah, sounds like she
but
has a lot
it's
of
just
strengths.
coming into something where it's structured and you have to abide by this until just the process and stuff. So we'll see how it play out, but it has been very challenging for me to yield and not be like poked and activated, and to come back. Don't say anything, like you say, just nod, and then we'll come back in that space where we can apologize to each other and she come down. But again, I see her because she's used to doing how she, navigate in survivor's mode and stuff, and have to come into, you have to abide by these rules, and as a younger person and you feel you got more skills and wisdom, but this is the operation that is in place under the program that I am running. And this is what you agreed to. So you have to submit and yield. So I think that's the underlying issue that's happening, that I got more I can do it better than you, or I've done this already and you're not doing it. Like, I'm like, but it's not your program. So
Yes, but do you have to say, but it's not your program?
no, I didn't say
You're
that to
thinking it. Okay, yeah.
I let her know that
You'll get to a point where you won't even think it. These skills will just like no one will even be able to um just recondition your brain on it every single time. Just every and I know you're doing it. You're doing it because you're telling me you're doing it. And it's just that one time they get you. Maybe you're hungry or something. No, I don't
and
know,
that's
but
the thing too, because it has been very contentious and people have hit below the belt. So I'm like, okay, yeah, but we'll come back and apologize. But I'm like, we got to do better than this because this is not, we modeling and I should
yeah.
know better. But again, I'm human and I have my
Yes, you are.
activation buttons and we're in a
Mhm.
close space. So, and that's part of this process.
It is part of the process. And early in the field, definitely. I would say many times I would be like, well, you're court referred. You can't do this. And now at the time, no clients I have even know any type of buttons I have. It's just not even close to they would even know. And it's just very slow. Motivational interviewing skills. Have you heard of that? Motivational interview. There's a client workbook or even some free worksheets online. Maybe before you know you're about to deal with some frustrating clients, go read some open-ended questions or change talk questions and really you like just be like, you know what I'm going to do as a goal? Every time I work with this client, I'm going to only use motivational interviewing skills. That way you're building your professional development and skills. And also you'll be able to see the results. It'll be like your own individualized case study, and to where you're really just gaining those skills, but it does take practice. Nobody enters this field with 100% trauma informed care and can navigate every single client effortlessly, right? So, yeah, I appreciate you sharing her because these are all probably why you're even in here because we never want to dread um someone on our caseload, right? Because we feel like we're doing ourselves a disservice, the client the disservice, and then there's some internal conflict going on because we're going against our own values and morals, but we're not really quite sure where to go, and we know that they need help. And just like Christina was saying, like it's hard to watch. It's really hard to watch these clients suffer, and we don't take on their successes, we don't take on their failures, right? And she may need a failure to learn from it, and then it's not even a failure, right? But it really is just everyone has their own individualized journey as long as we're just doing what's in our control, and that's the our trauma informed care that we can do no matter how frustrating it is, because it's frustrating. I know. I know. The learned helplessness in some clientele is extremely frustrating, and that's why knowing how ACEs impacts brain development and all these things. It's like they do not have the resiliency factors that we may have, right, to have gotten us to these things. And they're building those resiliency factors in the house, which is huge. So I thank you for sharing that. Does anyone else have anything to say about maybe the one or two trauma-informed care aspects that we looked at so far? Have you found that it's working with some clients, or have you found that anything else you want to add before we go to number 3? All right, number 3. This is encouraging. Hold on, I need to minimize my screen here. Encouraging resident empowerment and choice. So we talked about it a little bit, but trauma strips individuals of power, right? And it's something so terrible for a human to go through, is being stripped of their power, being stripped of their power of choice. So offering choices helps restore autonomy. So some of the cases that we've talked to, offering multiple options probably wouldn't be the best. If we are working with a client who is one of those more difficult or high risk, we're not going to want to present multiple options. We may ask open-ended questions of like, oh, how would you feel about going to a different resident's home? And if they say, I don't like it, you would say, oh, why not? And just listen to them for a little bit. At that point, it's not arguing with them. Just why not? Just open-ended questions, listen to them. And then if they're taking too much of your time, we'd be like, oh, well, thank you for sharing that with me. I'm going to go, and then do what you're going to do and then revisit that, right? And that's where you're just slipping a little bit of trauma-informed care underneath them to where when they're ready. But for clients who have a pretty good ability of resiliency, and you can use your insight and see that they're understanding where they're at in their recovery process, that's where you can present multiple options, so that we're offering residents a choice between housing activities. We're not doing individualized care. Like, we go to this AA barbecue every Sunday and you have to go to it, right? We're like, well, there's a couple different things you could go to. Which do you think would benefit you more, right? Because we know what benefits us the most. Not all the time. And I'm not saying that the clients that you work with will know that they know what's best for them. But it's also, they need to, while they're gaining their support and they have a little bit of a safety net with everyone's in there, they need to, even if you know that they're going to choose the wrong decision, don't tell them they're choosing the wrong decision. You just say, let them choose the wrong decision so they can get that consequence and they can learn from it. Natural consequences are huge for human development, right? Especially when they're have the support system to fall back on, because we don't want to choose everything for them and then they leave the house, they graduate drug treatment, they no longer need a case manager, and then they make their first bad decision, and what's going to happen? They're not going to have any coping skills or learned behaviors to understand how to navigate that bad decision. Collaborate on goals. Invite residents to work together with you to set their recovery goals and determine the steps needed to achieve them. This fosters a sense of ownership over their progress. Even just these little tiny shifts and change really just allows that trauma-informed care to be placed in. Highlight strengths. So we're going to emphasize the residents' existing capabilities and resilience, reminding them of their ability to overcome challenges and make positive changes in recovery. I know some of this stuff may sound corny, but the corny stuff works. I promise you this. Allow pacing autonomy. Give residents control over the pace of their recovery process rather than imposing a predetermined timeline. This respects the individual needs and promotes self-empowerment. I know sometimes you guys may have time-aligned goals like, oh, we only have payment or space for, let's say, 2 months in this recovery house. So we don't, there are some sort of time restraints, right? But everything is basically kind of gone on their individualized progress, not necessarily like a timeline. So really just highlight strengths. Focus on how you can navigate up that way. Recognizing and managing triggers. So a lot of the times, every single day, basically, if you're in a household or you're working with clients, you're going to see them being triggered by someone. They may not even share it with you. They may not even know they're being triggered. And this can be a substance use trigger, an emotional trigger, a behavior health trigger, any type of trigger, right? So you're going to want to be observant of changes in resident behavior or mood that could indicate they've been triggered. This usually is like the client is agitated, they seem withdrawn, mood swings. Ask residents about their known triggers or better understand their experiences. I have a client in one of my households. I've noticed, I didn't say anything to him, but I was just kind of noticing him over a couple months, and I noticed that it was right about, and I didn't know when his Wtech shot was, but right about around that time, you could see a couple days before. And I was always like, what? At first I thought maybe he's using, and then no, it wasn't that. And I was like, maybe this. And then it was like all kind of clicked together, right? And it was just in the very back of my mind between all the clients that I have. And it wasn't necessarily something that was too high of a risk that where I would need to talk to him about it. But it's just good to know, where all your clients are, because a change in medication or a change in routine or relationships, or just knowing if you see them having a mood swing, you could talk to anyone that you have a release of information for, depending on whatever HIPAA or confidentiality laws you're going by, of like, hey, do you know any information about this? Just active communication, right? And so when you approach with compassion, let's say someone does show a positive on a UA. So we're not going to blame or criticize them. Or if you see that they're having mood swings, you're not going to go over there and be like, what the heck's wrong with you? You're acting like a butthead, right? Because they're going to say, I mean, what are you going to do if you're having a mood swing and you're feeling agitated and someone's like, says that to you, right? You're not gonna be like, oh, well, especially if that safety or rapport is not already there. If you think you already have the rapport with the client, you could definitely be like, bro, what's up? And they'll share with you or not. So trauma responses are often outside the individual's control. So we're going to want to meet them with empathy and understanding. If they're being completely irrational, knocking on people's windows, threatening to burn down buildings, like Christina was sharing, we're going to approach them with compassion, but it's not something that is allowable, right? So provide coping strategies. So assist residents in recognizing their own triggers and developing personal coping mechanisms, such as grounding techniques, deep breathing, sensory awareness exercise, or redirecting to something calming. So an example of this is oftentimes in group or individual sessions, a client will share like, I've been wanting to use. And I'll be like, well, why? They'll usually say a more specific trigger, like the game was on and I wanted to drink, or someone drove by and they were playing trap music, smoking a blunt, and obviously they wanted to use, And so I was like, well, what were you feeling around there? And they would be like, oh, I was stressed out. I didn't get the job I wanted, so you're stressed. Okay. What have you found that have worked when you're stressed before? And if usually they'll come up with something, but if they can't and there's other people around, I'll be like, hey, what do you do for stress? And it's really easy. You guys have all done this. These are all just bare base minimum things. We don't want to overthink coping skills because they're so easy, right? Listening to music, going for a walk, drawing. Everyone has different ones, right? And so they'll give them a different one. And we kind of just give some psychoeducation on well, every time you felt stress, you use stress, use stress, use stress, use. Sometimes I'll bring up Pavlov's study, whatever, but we've conditioned the brain. You feel stress, you use stress, use. So we want to reprogram that with you feel stress. Now you go on a walk, stress walk. You'll reprogram it, whatever. And it's a longer conversation, but you guys kind of get the gist of what I'm saying. And that's gaining them with the open-ended questions, their own tools and their own ideas of like, oh, well, sometimes when I'm stressed, I play the guitar, but I don't have a guitar. And then we can make a goal of like, well, let's get some guitar, going. And there's been times where I've emailed gyms in town, guitar lessons, all these different things. Like you guys do not have time for this. I know I do not have time for this, but maybe someone on your team does. And they'll donate like, oh, if someone passes UAs, they can have a free month of boxing or something. And just having the community network really identifies those coping strategies. Maybe they do have enough in their budget to be able to pay, or maybe they can give guitar lessons at a studio for guitar. Anyways, I'm going on a kind of rant by that, but the coping strategies are endless, but the main thing is getting them to identify it themselves, because maybe my coping strategy is I don't know, I have tons of them, I promise. I just can't think of any right now. Maybe my coping strategy is going for a walk, but so-and-so does not want to go for a walk. They work for retail all day and they're walking around all day, where I'm sitting on a chair all day, so I want to go for a walk. Maybe, but if I'm saying you need to go on a walk when you're feeling stressed, it's not gonna hit them, right? But if they think of their own that applies to them, they're gonna be wanting to do it more. So modify the physical environment to minimize potential triggers, such as reducing loud noises, removing confrontational imagery, and ensuring the space feels clean and well lit. So those are just little things that you can do. It may not be in your that may not be in your job description, or it may not be something that you're required to do, and it's not something you have to do. But let's say you're going to go check in on someone in the lobby of wherever they're staying is just terrible. You may tell the check-in person like, hey, I'm not sure if you're aware, but what you have going on here could disrupt some of the people that you have. You might want to change it. They might not do anything, Or you could even show compassion to the resident of like, oh, I noticed the lobby a lot of it is kind of dark and messy. I'm sure that might be frustrating to you, maybe avoid it, or just those little tiny things, right? It may not even be necessary, but you guys can use your own insight to see what's going to be necessary for your clients. But those things can trigger someone. If someone's already in a bad mood and they have to go through a dungy lobby with like a weird, I don't know, scary picture on the wall or something. A lot of times people aren't aware of what type of artwork they have up, or maybe right next door is a bar to, kind of close to their house. It's just a whole bunch of different things. Just be aware of their environment and how they can create safety from it. And then, so what number is this? Oh, it's number 5. Sorry. So the last one I want to talk about is de-escalation techniques. So these are all trauma-informed care. So you can say, I'm trauma-informed and provide trauma-informed care. And this is out of the box, but that's fine. So de-escalation techniques, they're simple. You guys do them already, I'm sure of it. So remain calm. Sounds simple. Your demeanor sets the tone for the de-escalation. Stay calm, speak softly, and avoid making sudden movements. This is basically, see them in your brain as like a timid cat or something. Like, you're not going to say, you need to be calm, because that's not going to work. You're not going to overpower them and make them calm, right? You're just going to remain calm, speak softly. You're not going to be jumping up and moving around, right? You're just going to try to de-escalate the situation. And you're not going to do that by trying to power move them. It's not going to happen. Redirect attention. If the resident is stuck in a heightened emotional state, gently redirect their focus away from causing the distress and towards something neutral. Can be done. Validate emotions. Acknowledge the resident's emotions without condoning any harmful behaviors. Validating the resident's feelings can help them feel understood and less defensive, less isolated. People lash out when they feel isolated. Create space. If needed, allow the resident some physical space or offer them a choice to step away from the situation. This gives them time to regain control of their emotions. Now, again, this is all just if someone is escalated. If someone's escalated to the point where they are threatening harm to themselves or someone else, this you're going to need to call crisis response or police. I hope you all are aware of that. I'm sure you are. But these are just things in like attack mode or there's some conflict. I printed out 15 fair fighting rules and hung that up at the residence home I'm working at on their fridge yesterday. And I was like, I need on Monday, you guys are, whoever wants to share is going to share with me like how you use these tools this weekend. Because it's hard. Can imagine how hard it is to live in a house with that many individuals, especially they're all in early recovery, probably going through pause, trauma, ASS, all those things. So, yeah, creating the safe space and de-escalation techniques is hard, especially if you are being triggered. And these are all just things that take practice. Do any of you guys feel like you guys have successfully de-escalated conflict within a client care?
Absolutely.
Perfect. You want to give me an example of that?
Sure. There was a situation on, what day is today? Thursday? On Sunday, where an individual had checked himself into a mental health facility because he's going through a divorce and his kids don't want anything to do with him. So he came back to the house and was apparently stabilized, had been medicated, and said that everything was okay. There hadn't been a conflict or anything for him to go to the mental health facility. He just kind of went there. I guess he was having some issues. So fast forward to Sunday, he was taking a shower at 4 o'clock in the morning, was banging on the wall, did some damage, and woke everybody up. Got physical with one of the gentlemen that's there who's elderly. And so I was called, and we have a policy about being physical with or assaulting residences and doing damage. So there's not really anything to talk about. So I had brought the housing agreement that he had signed, saying that he would, remove himself from the premises if he violated any of those rules, and he, um, ripped it up, threw it in my face, got in my face, was trying to get physical, and that triggered some negative thoughts with me. So instead of yelling, I tried to speak calmly and slowly, and you know, just tried my best to kind of change the subject into him getting the help that he needs, and that that it's gonna be all right. But it was very, like, in my face, loud and threatening, and that could have went really bad. So
Mm-hmm. Yeah, I'm
that
sorry you had to go through that.
well, it's just one of those things. Um,
Yeah. And I'm
people
glad
don't
you
tell me
powered
that
through
because
just to see like the benefit to your client at the very end. But that is something that we should not, yeah,
yeah,
absolutely should not be having to deal with. But
yeah,
yeah, good job
right.
de-escalating.
Yeah, right.
It can be hard, especially when yeah,
Yeah,
they're lashing out.
yeah,
All right, so you guys have all just got 5 trauma-informed techniques. Hopefully you guys can all apply them and keep encouraging them with you and your staff. Sometimes I use these trauma-informed care with my staff, right? I just in my if I'm dealing with there for some reason colleagues in this field, they really like clash, and staff meetings can be absolutely nightmares. Sometimes I use these in there too, right? We're all just clients in the end, in the end of things. Um, so what I want to end with today is self-care for practitioners. So the best thing you can do for trauma-informed care and ACEs is make sure that we are taken care of, right? I need to minimize this again. So we're going to recognize signs of burnout. So be aware of physical, emotional, and behavioral indicators of burnout, such as exhaustion, detachment, and decreased productivity. And I hope you guys all have like a list of 3 things you need for when you're feeling yourself burnout, which is such like a terrible term because burnout could mean so many different things to other people, but you're going to need, maybe you need a mental health day from work, call in sick. Don't tell anyone I recommended that to you. And then, yeah, just know that you guys all have your own coping skills. Practice self-reflection, which it sounds like you guys are, if you guys are sharing client cases and frustrations and biases. Regularly engage in mindful self-reflection to identify personal needs, stress triggers, and areas for growth. This is where collaboration with teammates in the field is so important to be able to talk to, because we really understand each other and what we're going through. Of course, don't share specific client cases with anyone outside of your workplace, but just share how you're feeling. Like, maybe you guys need to go to out of town vacation training, or just something fun to really reboost you. Establish healthy boundaries. Set clear boundaries between work and personal life, and learn to say no to maintain a sustainable workload. This practice is huge. Don't be waking up in the middle of the night thinking about you're hoping your clients had a house. It's really hard when we're working with housing and employment and the clientele we're working with. But it's really just going to benefit every future client you work with if you're able to establish a healthy boundary. If you do not have this boundary, please reach out to myself, people in the field that you work with, supervisors. This is one of the most important boundaries. You're going to want to separate it. Your home life is and personal life is of the utmost importance to be enjoyed. Engage in stress management techniques. Again, I hope you all have a list of stress management techniques, because when you are on high stress, you're not going to be like, let me go research stress management techniques. You just want 3 in your brain to be like, let me try this right now. I need a little break. Take those short little walks around the walking breaks. Make sure you have some good songs to listen to, nothing that's going to engage stress, right? Meditation, exercise, creative hobbies. And so when we're talking about stress management, of course, there's the stress management techniques to do right then, but there's also the precursor stress. So let's say if you're eating eating right and exercising daily or whatever you guys find fit each week, every day or whatever, when a stressor occurs, you're not going to respond to it that hard as you would if you're not taking care of yourself. We all know it. Do we all do it? We should. Build a support network. Connect with colleagues, supervisors, or a professional counselor to discuss challenges and seek emotional support. Prioritize continuous learning. Participate in workshops, trainings, or continuing education opportunities to enhance professional skills and knowledge. We all know we should be doing this. You're going to be re-added to it literally every training you have, because it is so important and it just makes you a better professional. All right, we are at the end. Anyone have any open discussion, any insights you want to share, or questions? We made it. Do you all feel like you kind of understand ACES a little more or would like to research it deeper? No? All right. Well, I thank you guys all for joining with me today. Hopefully you got some tools you could bring home and utilize throughout the week.
If you guys can fill out a survey, I'm going to put a QR code up for you guys. Trying something new with the QR code. So give me a second.
I was just hoping that somebody could send me the slides, if
Yeah,
that's okay.
definitely. We could send them if you register to the email you registered, where we're gonna send those out.
Thank you.
Let's see, two. Okay. Okay, can you guys see that QR code up there? Sarah, can you see it?
Yeah, I can see it.
Okay. Perfect. And yeah, if you guys fill out the survey, you can hop off. If you don't feel like filling it out, that's okay. We can send it again during when we send the video recording and slides. So if you have to hop off, but it's just helpful for us.
What's the name of this survey? Or what's the name of this webinar?
Childhood trauma and ACEs.
Okay. Thank you.
Yeah.
Sandra, you may also be able to look for a peer support or whatever field you are in, online support group to decompress, maybe like once a week or once a month, meet with the professionals so you can decompress that way as well.
Mhm.
On that issue, guys, I know where we work, we encourage our staff to have a counselor that we go see regularly. And I do that. And the reason why is so I have a safe place that I can unload. like, because I deal with clients passing from drugs, and that's an important thing for me. We also have regular staffings where we get together and talk about these things. And you know what you were saying about your employer won't like it if you have a mental health day. I have an employer that they encourage us to sit down and do a self-care plan. And that's one really good thing about ours. And our place does honor and encourage us to take mental health days. So there are employers out there who do that. And I just wanted to let people know that.
Yeah, I'm glad you have that. My employer does that as well. It's huge. Game changer. So if you are ever employers, make sure you implement that.
Okay, hopefully everyone who's filling out the survey was able to pull that up with the QR code and can finish it off your phone. I will be closing the meeting. If you do need a minute, please let me know. I could leave it up for longer. We'll give it another minute. Thank you everyone for being here. Thank you so much, Sarah.
Thank you for having me.
Yeah.